Tell me something. In the 1990s, a highly effective HIV prevention program was developed in the United States. It was evidence based, it was rigorously evaluated, it worked. It was then exported with minimal modification to sub Saharan Africa. It did not work. The program had been built on assumptions about the individual autonomy in sexual decision making that did not hold in cultural contexts where sexual decisions are made within networks of family obligations, gender power dynamics, spiritual frameworks, and community norms that the original intervention had never been designed to address. The evidence base existed, the cultural fit did not. An intervention that works in Boston does not automatically work in Botswana or Lagos or Bangkok. The failure to understand this has cost lives and wasted billions in global health funding. Before we begin, an important note. This episode is for educational purposes only. It's not a substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. Content draws from An Introduction to Global Community Health Psychology, published by Routledge in 2026, and from peer-reviewed academic sources. Always, consult current guidelines and qualified professionals. If you are experiencing a health concern, please seek qualified professional support. Links are in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS MBA, MSc MPH, PhD, Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria. Series 1, Foundations, Episode 8. Today we cover Chapter 5 of An Introduction to Global Community Health Psychology, Applications at the Intersection of Health Psychology and Public Health, published by Routledge in March 2026. Chapter 5, Cross-Cultural Research Methods and Applications. Simply put, why your evidence-based interventions fails when you cross a border. In this episode, the ADAPT-ITT framework for systematic cultural adaptation of evidence-based interventions, the Kaupapa Maori research, and what Indigenous research methodologies demand of institutions, the OCAP principles in practice, Decolonising methodologies and what they actually require, not as rhetoric, as research design, community consent processes that go beyond individual informed consent, and measurement invariance testing across cultures. The definition of insanity is doing the same thing over and over again and expecting different results, often attributed to Albert Einstein. Exporting the same intervention, unchanged, into different cultural contexts and expecting the same outcomes is the global health equivalent of that definition. There's a systematic process for cultural adaptation that the evidence supports. Most programs skip most of it. The adapted framework, assessment, decision, adaptation, production, topical experts, integration, training, testing provides the most comprehensive guide available for adapting evidence-based interventions across cultural contexts. Assessment phase means understanding the target community's cultural context, the health beliefs, the social structures, and communication patterns. This requires months of genuine community engagement, not whisk of desk research. Programs consistently underestimate the time required for authentic cultural assessments. In the decision phase, we need to determine which elements of the original interventions are core, theoretically essential to the mechanism of action, and which are surface-level adaptations that can and must be modified. The core elements cannot be changed without losing what makes the intervention work. Surface elements must be changed to achieve genuine cultural fit. Adaptation, production, topical experts, integration, training and testing, piloting with the community, evaluating outcomes, refining before scale. Research from Latin America, Sub-Saharan Africa, and Southeast Asia context documents that assessment phases routinely require 40 to 60% more time than budgeted because of the relationship building that authentic cultural understanding demands. Give me 6 hours to chop down a tree, and I'll spend the first 4 sharpening the axe. Abraham Lincoln. Program that shortcuts the assessment phase, produce interventions with cultural veneer rather than cultural fit. And cultural veneer does not produce outcomes. What does it look like when research is rebuilt, not reformed, from the ground up around indigenous values? The Kaupapa Maori research, developed by and for Maori people in Aotearoa, New Zealand, represents a fundamental paradigmatic shift from Western research frameworks. In Western research paradigms, the research is positioned as an objective external observer who extracts knowledge from the community being studied. In the Kaupapa Maori research is conducted by, with, and for Maori communities, using Maori cultural values as the foundational framework. This is not simply about including Maori researchers in existing research structures. It's about rebuilding research around different ontological and epistemological foundations. Different assumptions about what reality is, what knowledge is, and who has the authority to produce it. The OCAP principles: ownership, control, access, possession, operationalize indigenous data sovereignty in practice. Communities control what research is conducted. Communities own the resulting data. Communities determine how findings are used. Not until we are lost do we begin to find ourselves. Henry David Thoreau. Western research institutions have for generations found themselves by losing communities. The Kaupapa Maori research proposes a different arrangement, one where the community does not have to lose itself in order for research to happen. This is the most politically charged section of this episode. It's also the most empirically grounded. Linda Tuihiwai Smith's foundational text, Decolonising Methodologies, was first published in 1999. It described research as one of imperialism's primary instruments. It's a mechanism for extracting knowledge from colonized communities and using it to serve the interest of colonizing powers. Decolonizing methodologies challenge this relationship at every level. In the research questions asked, in the methodologies employed, in who benefits from findings, and in how knowledge is communicated and credited. Contemporary decolonizing approaches extend beyond the indigenous context to any community where knowledge has been systematically excluded, where knowledge has been misrepresented, and where knowledge has been appropriated by mainstream research traditions. You see, the practical implications are significant. Reciprocal research relationships where communities receive immediate benefit, not just acknowledgement in a paper they will never read. Community control dissemination, traditional knowledge transmission processes respected and incorporated in research design. Until the lion learns to write, every story will glorify the hunter. African proverb. Global health research has for too long been written by hunters. Decolonizing methodologies insist that the lion learns to write, and that what the lion writes is taken seriously. We learn about informed consent in our first research methods course. Sign the form, tick the box, proceed. Traditional informed consent models were designed for individual participants in controlled research settings. They are inadequate, structurally inadequate. For community-based research in collective cultural context, where individual decisions have community-level implications, many indigenous and traditional communities require collective consent processes, extended community dialogue, traditional authority consultation, and consensus building before any individual consent can be ethically obtained. Ongoing consent mechanisms recognize that consent is dynamic. Communities may consent to participate in a study while reserving the right to withdraw consent for specific data uses, or to require review before publication. Research designs must be flexible enough to accommodate this. Consent is not a checkbox. It is a continuing conversation. The ethical standards in cross-cultural community health research is not, did individuals sign a form? It is, did the community meaningfully and participate in decisions about how its members and its knowledge will be used? Those are very different standards. A brief but critical technical point. One that determines whether the data you collect actually means what you think it means. When a measurement instrument is used across cultural groups, a fundamental assumption is being made that the instrument measures the same construct in the same way with the same psychometric properties across all groups being compared. Measurement invariance testing evaluates whether this assumption holds. Configural invariance. Does the same factor structure apply across groups? Metric invariance. Are the factors loadings equivalent across groups? Scalar invariance. Are the item intercepts equivalent, allowing meaningful comparison of means across groups? Most cultural health research does not report invariance testing, which means most cross-cultural health research cannot confirm that its comparisons are valid. In God we trust. All others must bring data. W. Edwards Deming, statistician. And the data must be valid, not just collected. Valid. The most effective cross-cultural health interventions are not imported programs with translated brochures. They are programs that were built with communities, that started from the community's own understanding of its health challenges, that mobilized the community's own knowledge and leadership, and that treated cultural context not as an obstacle to overcome, but as the primary source to build from. Culture is not a barrier to health. It is health's most powerful delivery system. The evidence for this is not theoretical. It is documented, replicated, and available to any program designer willing to read it. The question is not whether cultural adaptation is necessary. The question is whether institutions are willing to invest the time, the relationship, and the genuine power sharing it requires. This episode is based on Chapter 5 of An Introduction to Global Community Health Psychology, published by Routledge in March 2026. Chapter 5 is the chapter that global health funders most need to read. The evidence for cultural adaptation is now irrefutable, and the cost of ignoring it is documented in failed programs across every region. The full textbook is available on Amazon.com and on Routledge.com. Multiple payment mechanisms, multiple cards, links in the description. Episode 9 covers Chapter 6, Stress, Coping, and Resilience Across Cultures. The question, why does stress feel different depending on where you were born? If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers. Link in the description. The Practitioner's Course in Global Community Health Psychology is available on gumroad.com. 8 weeks, everything this textbook covers, built for practice, link in the description. And the textbook itself, An Introduction to Global Community Health Psychology, is available from Routledge and on Amazon.com. Everything begins there. From the director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria, health is not destiny. It's been Dr. Anthony Iyore Anaweokhai. I'll see you on the next one.